Invite Dr. Avnindra Gupta to.
Thank you, Ritesh, for introducing all the members. And this is OCT angiography, navigating the teenage tantrums. Coming to the interpretation and comparison of the machines, Octa was first introduced in 2014. It's a new armamentarium in retinal imaging. Is fast and non-invasive and is dye-free angiography and HD OCT in one machine. Prior to Octa, fluorescein angiography and indocyanine green angiography were the mainstay of modalities for retinovascular visualization. Fluorescein angiography and ICGA generated two-dimensional in-force images of the retinal vasculature. Octa allows individual visualization of retinal capillary plexus. If we come to the conceptualization of OCT angiography, the basic concept is angioplex detects motion of scattering particles such as red blood cells within sequential OCT B scans performed repeatedly at the same locations in the retina. Each clusters of OCT B scan and each cluster is acquired in the same position on the retina. Each cluster generates one blood flow scan, and then the angioplex image is reconstructed like this on an NFOS image. The software what we use in ZEISS is OMAG-C software. OMAG is an imaging technique which uses the complete complex OCT data signal including amplitude and phase, and this is the only machine which takes amplitude and phase together. If we look what is OCT, what we do, we take a cross-section of the retina. Like if we cut a cake like this, you will see the cross-sections in the cake. This is a chocolate part, this is a cream part. And OCT, we take a cross-section of the retina where we see multiple layers of the retina. In OCT, what we do, we take an NFOS image and we cut the retina or slice the retina to have multiple layers of the retina. So if you see the video of an Octa, what you see here, this is an segmentation line. And as this segmentation line moves, you will see different layers of the retina, which is vascular, avascular, and superficial retina. So the moment you see this line reaches the choroid, you can see the disease pathology coming up. So you know the disease pathology is at the level of the retinal pigment epithelium or the choriocapillaries, and you can see a nice branching vascular network. And if you move on, you can see the segmentation line moving. We can see the NFOS image of the choroid, and here you can see large choroidal vessels. So it's very important to learn here about the segmentation line, because segmentation, a good segmentation and how to do a good segmentation will give you a lot of information over a period of time. Same thing we'll repeat in this video. This is the non-invasive dye-free angiography with single scan simplicity. The motion of red blood cell is detected by sequential OCT. It is performed repeatedly at same location. Based on the properties of the light reflected from RBC, motion is detected and vessel with blood flow are identified. Real-time tracking of the eye movement with fast track results in motion artifact-free images, which is available in few machines like ZEISS and Heidelberg. Fast track immediately recovers from eye movements and blinks, so you don't see motion artifacts in these kind of OCT pictures. OMAG take full advantage of the amplitude and phase from the OCT and gives multiple slabs of the retina. This is the superficial slab, the deep retina, avascular slab. Each slab is color-coded in red, green, and blue, and a comprehensive image is then generated. Then you get this reports, and you have multiple slabs here. This is an angioplex image. This is a structural image, and you have an B-scan image with flow overlay. It can be a spectral domain OCT, or it can be a swept source OCT. Spectral domain uses 840 nanometers and swept source uses 105 nanometers. So the longer the wavelength, the penetration is great, and you can image the choroid better in swept source OCT. It's faster and has a greater area of scanning. But the disadvantage is resolution is less as compared to a spectral domain OCT, and the cost is double as compared to the spectral domain OCT. If you look at the interpretation of the OCT, as a general rule, 3 images must be concurrently assessed for accurate OCT interpretation. The first image is an angio image or the NFOS image. You have a corresponding B-scan with a flow overlay, and then you have a structural OCT. So image the right spot where you have a lesion, then look at the NFOS octa images, look at the segmentation line where the lesion is, and actually it's very important to look at the segmentation line very nicely, because if you segment the retina at a wrong plane, you will not get any kind of information. Like in this patient, you can see an image in the choroidal or the choriocapillary layer showing CNVM, and this is the structural image. So sequentially, you have to see all the images to come to a conclusion. Simultaneously, you have to see a flow overlay, plus you have to see which area you are segmenting. Image the correct spot. Depending on the type of lesion, you can choose the block size. If you have a macular disease, you can take a 3 into 3 millimeter block or 6 into 6 millimeter block. And if you have to look for areas of capillary non-perfusion, then you can go into 8 into 8 montage or 12 into 12 montage. You can see this is a macular picture. You can see a nice CNVM where you need a magnification, and the lesion is small. You can go into 3 into 3 blocks. If the lesion is bigger in the macular area, you can go into 6 into 6 block. And if you want to see new vessels and areas of capillary non-perfusion, you should always go for 8 into 8 montage, or you can go into 12 into 12 montage, which takes areas above and below the arcades. So you can see areas of capillary non-perfusion and neovascularization in these patients. There are various presets available in all the machines: superficial, deep retina, avascular retina, choriocapillaries, choroid, and each of the segments I'll be discussing in detail. Superficial retinal slab extends from superficial retinal slab, ileum, ganglion cells, and inner plexiform layer. What you see, the important thing here to see is the foveal avascular zone, and in these patients you will see areas of capillary non-perfusion which can be identified in superficial retinal slabs. Deep retinal slab extend from the inner nuclear layer, the outer plexiform layer, and the intermediate and deep capillary plexus. OCT is only clinically available commercial imaging modalities which can image the deep capillary plexus. You can't image with FA or ICG. Octa with Heidelberg, you can also interpret intermediate capillary plexus, which you can only do in Heidelberg machine and not other machines. With this disease, you can diagnose a lot of disease like PAM, or the layer where the middle layers are affected, or the middle deep capillary layers are affected. The outer slab is an avascular slab. The presence of any vessels in this area usually is an indicator of pathology like CNVM. Choriocapillary slab is defined as a 20 micron slab below the retinal pigment epithelium. What you see here, the segmentation line is at the level of choriocapillaries, and here on the angio image you can see neovascularization. This is another patient. This is a sub-RP slab. What you can see, the segmentation line takes the projection artifacts, and what you can see here is an polyp with a branching vascular network. ORCC slab is a combination of outer retinal slab with choriocapillaries. It was first described by Rosenfield. This slab spans with the outer plexiform layer, the outer nuclear layer, and the choriocapillaries. So it's a wide slab which involves the choriocapillary and the avascular zone. In this slab, you can nicely identify CNVMs, like in this patient, and here is another patient where you can see a good CNV image. Choroidal slab is 50 microns below the choriocapillaries. Difference in wavelength and light source lead to variable detection of choroidal vasculature between devices. And you can see nice choroidal vasculature in choroidal slab, and if you have an pachychoroid disease, these vessels will be dilated. I've been mentioning again and again about the segmentation line. If you don't segment your lesion at the right place, you will not get an accurate information. So this is, you can see there is a structural image, you can see a pigment epithelial detachment. And if we see there are projection artifacts, and at the margins of the pigment epithelium, you can see a branching vascular network. So this patient was of polypoidal disease, and we can diagnose branching vascular network in this patient with the right kind of segmentation. You have to sit on the machine and roll the segmentation line to come to a conclusion. Another important thing is a B-scan flow overlay. What is flow overlay? What the red dots, what you see here, and the green dots, what you see here, this signifies the amount of flow in the vessels or the abnormal vessels. So anything, you have to put the B-scan cross-section here, and simultaneously, if you see the flow overlay here, the green spots have increased. That means it's a high flow lesion and is an active lesion. Many a times you are not able to, because of the media opacities, you are not able to make a good diagnosis on angiogram. In this patient, there was a medial opacity. We couldn't image the NVD, but on structural OCT, you can see a fibrovascular proliferation, a vitreous hemorrhage, which will give a diagnosis, yes, this is a patient of proliferative diabetic retinopathy. You can also have a comparative angiogram pre-VEGF and post-VEGF, whether the lesion is increasing or not. You can see comparative CNVM here, which is small, and in this picture, it has increased over a period of time. Coming artifacts, Ritesh will deal. Coming to the comparison of machines, the machines what are available is Zeiss Angioplex, 6,000 and 5,000. The difference between 6,000 and 5,000 is 5,000 gives 8 into 8 slab and 6,000 gives 12 into 12 slab. Topcon, you have an Maestro is in spectral domain OCT, and Topcon Triniton is in SS OCT. Heidelberg, Optopol, and Optoview. If we look at a Topcon machine, there is no tracker, and the block size is, the largest block size is 6 into 6. So in this machine, you can only scan the macula. You can't look at the peripheral lesions, and it's very difficult to identify. So it's only limited to the pathology of the disease in the macula, not beyond the macula. The images, once you increase the block size, the images are not very clear. But if you compare with SS OCT, the images are much better in SS OCT. Heidelberg, this is one of the best machines what I have seen. I think Puneet will show you the photographs, and you will get impressed with this machine. And the depth or the axial resolution is 3.9 microns as compared to 5 microns in Zeiss. But the only disadvantage is it gives 9 into 9 slab. So imaging the peripheral retina is not so good in Heidelberg as compared to Zeiss. Optoview, I personally has not seen this machine. The pictures are not very good. So I will not recommend Optopol review to your patient, to you. So to conclude, all three images, NFOS, Octa images with structural images with B-scan overlay should be assessed for the correct diagnosis. In doubt, always sit on the machine for correct segmentation and B-scan overlays. It is an evolving technology with a lot of thing to learn over a period of time, and a lot of development is occurring in OCTA technology. So every time we'll come with a new information about this machine. Thank you very much for your kind attention.
Thank you, sir, for a lovely disposition.